Hello. Hello, everyone. How you going? Just waiting another minute or two. A few people are still coming in. My name's Casey, by the way. I'm a doctor working out of Queensland, rural Queensland, actually, in a little rural practice. Got an interest in weight loss medication, so ozempic, Saxenda, Mounjaro, which is the new one that's hopefully coming out in the next couple of weeks, Wegovy, which is the bigger dose of semaglutide or Ozempic. So I've just created a little series on weight loss. So tonight is our first one, the introduction to weight loss medication. We'll be going over a couple of things tonight. So really tonight is giving you an idea about how weight loss medication works, what's available, what other medications other than the injectables are around, and a bit of a Q&A at the end of it as well. We're running, or I'm running a 4-series session. So we've got the one tonight, and then a fortnight from now, and then so on every 2 weeks for the next 2 months. The next one that we're going to be doing is the top 5 most effective weight loss medications. So if you're interested in learning which one works well or works the best, the most effective, we'll go over that as well. That's in a fortnight's time. New weight loss medications, that's a couple of new ones that are coming out. So similar to the ones that I mentioned before. So the new ones coming out that we're really excited about is Mounjaro. That is similar to Ozempic, plus it's got another medication in it. So it's very, very, very effective. So up to 22% weight loss on that one. And there's a few more studies of other medications that should be available in the near future being in medical terms, probably a year, 2 years, 3 years. And then there's another oral medication that's coming out as well. So it's an oral formulation of something similar to Ozempic. And then we're also going to go over some money hacks for cheaper medications and GP appointments. So just trying to go through and see if we can figure out how to make it a little bit cheaper for you when you go and see your doctor. It's expensive going to see the GP. It's expensive getting these medications, very expensive. So we're going to try and figure out some ways that we can make that a bit cheaper for you. So there's a few things that we'll go through, and we'll touch on some of those tonight. So tonight we're going to touch on a little bit of everything, hopefully give you some information about how it all works, go over a few of the side effects, some common questions, some common pain points, and hopefully that'll be helpful. So history of weight loss management. If you're wondering, and you're probably aware of this, especially if you go see some GPs that maybe not so interested in weight loss, they'll just say diet and exercise, that's all you need to do. Generally, diet and exercise doesn't do that much and is not really that effective. So there are a lot of studies saying that if you compared someone who didn't diet and exercise versus someone who did diet and exercise, after about 2 years, they're lost about the same amount of weight, which is not much. That doesn't mean diet and exercise isn't important and helpful. It is. It's always important to exercise. Exercise is really good for you. But for the purposes of weight loss, it probably doesn't add a whole lot. Then we had medications that are around. Most of these medications are actually just discovered accidentally. So the first one up there, topiramate, it's a medication that was used for epileptics. So they did some studies on people that were having seizures, and they gave these people that were having seizures this medication called topiramate, and they noticed that the people that were getting this medication lost a couple of kilos, almost all of them. So they then did some further studies and gave topiramate to people who didn't have epilepsy, and they lost some weight too. So it's a reasonably effective medication. It's very cheap. Costs something like $10 or $20, even cheaper, I think. Pretty good with side effects. Most people lose a kilo or two, maybe up to 4 kilos. It's not really used that much anymore. Another medication, naltrexone, that's one that we use for people that have opioid addiction, so people that are addicted to painkillers. We found that giving them naltrexone helped with their painkiller addiction, but also giving it made them lose a little bit of weight. And it seems to work on the same receptors that make us feel hungry and want to eat. So that was a medication that worked. Again, it's not particularly effective, a couple of kilos, maybe at the most. Duramine, that's another common medication. It's a stimulant. So stimulant being something similar, not the same, but similar to something like meth. So some people will call it medical meth. So if you have Duramine, you might feel a bit zippy zappy, you've got lots of energy. It increases your metabolism. So that's one of the reasons why you lose weight. It also makes you not hungry. So I know this is a bad mental image, but you sort of look at someone on something like Breaking Bad, that's that TV show, and the people that are addicted to meth, they're always very thin and gaunt because they don't eat, they've got a really high metabolism, so their body's chewing up a lot of energy and they're not eating that much anyway. So Duromine is like that. It's not, I don't want to say if you take Duromine, you're a meth, but it's similar to that. It has some pretty important side effects to be aware of. Does work pretty well. There are different doses of that, so 15, 30, and 45. Generally around 30 is optimal, but 15 is okay as well. The major side effect with that one is you do have a really big risk of having a psychotic breakdown, and I've seen that before in a patient. So a patient with absolutely no risk factors can have a psychotic breakdown just from using this medication. It's incredibly rare, but it can happen. Then the other medication was orlistat. So it was essentially a medication that just stopped you from absorbing fat. The main problem with not absorbing fat then is that when you go to the toilet, it's terrible. It's terrible, terrible, terrible. So you have incredibly smelly stools, incredibly rough time when you go to the toilet if you eat something that's full of fat. So it can be quite difficult, but it is effective and it does work. Then we had the surgery. So you may have heard of things like the gastric band, where they put the gastric, like the little rubber band around your stomach. Then we moved on to the gastric sleeve, where we sort of cut your stomach in half. And then we've now got Roux-en-Y and Omega loop bypasses. So fancy words for saying we just bypass the whole stomach. And they're very, very, very effective. And their side effects are getting a lot better, but it's still a surgery and it's not funded by the government. So you've got to pay privately for it. So it's generally around, if you don't have private health insurance, 20 grand. If you do have private health insurance, it can range from a couple $100 to a couple of grand, depending on what your private health covers. So it depends on what your private health is doing. It's still a big commitment. So weight loss medications, what are they and how do they work? Generally, they're grouped into three things. So things that suppress your appetite, so that's like ozempic, things that allow you to not absorb fat, so that's the orlistat, and then things that increase metabolism, so that's the Duromine. Generally, they're the three things that we look at. The ones that are most effective are the ones that suppress your appetite. So you're just not eating the calories as opposed to burning them or pooping them out after you're finished. They tend to work a bit better. So here's a list of examples of weight loss medications. So Contrave, Orlistat, Duromine, Topiramate, Saxenda, Ozempic, Mounjaro. Wegovy is another one. Wegovy is the same as Ozempic. They're exactly the same. That's semaglutide. They're just different doses. So Ozempic goes up to 1 milligram, which is for diabetics, and Wegovy goes up to 2.4 milligrams, which is for those who want to lose weight. So one of the things that comes up quite often is people are on Ozempic and they say, "Oh, I've stopped losing weight." Why is that? It's probably because you're just not at a high enough dose and you need to keep going up. The problem in Australia is because we don't have Wegovy, it's very, very expensive to go up to the 2.4 milligrams because you'd need, three pens to do that. So you need the two 1 milligram pens and then, half of a 1 milligram pen. So you'd be paying something like $400 or $500 a month just to sustain that sort of dosing. So very expensive. However, it's similar to Saxenda. Saxenda is about $400 a month as well, and it's not as effective. So it's possible if you could find the pens. There's a bit of a shortage at the moment, so it's tricky. But theoretically it's possible. So the pens, what are they? They're glucagon-like peptide-1 agonists, so GLP-1s. That's the sort of buzzword here. GLP-1s. They're a new class of medication. When we say new in terms of in the world of medicine, new means they're 10 years old. So there have been medications that are in this class been available for at least 10 years. So the early ones were called Byetta and Bydureon. They weren't that effective. They're really good at sugars. So if you're diabetic, they're really good. You had to inject them twice a day, had some side effects, weren't particularly effective for weight loss, but they're just getting better and better and better. And the way that they work for diabetics and weight loss is just becoming amazing at how good they are. And the amount of weight loss that patients can have with what seems like very little lifestyle changes. So I have a lot of patients that say, I feel like I'm eating exactly the same thing. I just eat a little bit less, and then they lose weight. And it's fantastic. So patients losing 20, 30 kilos is easy, very, very common. And they seem to be getting better as well. So Ozempic was sort of the big breakthrough. It's once a week, works really well. But then you've got Wegovy, which is the bigger doses. You've got Mounjaro, which is coming out hopefully in the next month. So that's an even more powerful version of a once weekly injection. So most people on that one in the studies were losing up to 22% weight loss. And then there are some others that are in trials at the moment, which we'll talk about in our next section, or the next session after, when we talk about the future medications. It's called Retatrutide, and it's got up to 25% weight loss. So that's comparable to having surgery. So you can take a medication and it's the same as having surgery, but you haven't forked out 20 grand and you haven't been cut open and have all these sort of side effects and things like that. So it's pretty impressive stuff. And then there's also a tablet version that will hopefully come out in the next 2-3 years, which is not as good as the injections, but it's about 10 to 15% weight loss, and it's just a tablet, so it's very easy to take. So how do they work? The GLP-1s work by stimulating a glucose-dependent insulin release from the pancreas. So what that means, blah, 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 fancy words for saying, if you've got really bad sugars, these medications work better. If your sugars aren't that bad, they don't work as well, but they still work very, very well. So if you're a person that's got really bad sugars, sugars are really high, diabetic, these medications seem to work very, very well. And if your sugars are only a little bit bad, they still work fantastically well, but not as good as someone else. So, for example, someone could have sugars up to, say, 10, and they put them on, your doctor puts you on this medication, and they'll come down to 7 or 6. If someone has sugars of 8, they won't go down by 4 again. They'll just go down by 2, down to 6. So they tend to work better if your sugars are worse, which is a good thing. They also slow gastric emptying, so you just feel full for longer. It's part of the reason why you get really bad reflux, because your food just sits there. There are some implications with that. If you're going to get some types of surgery, you need to let the surgeon, the anaesthetist know, even if you're not taking them for diabetes, if you're just taking them for weight loss, because they can do the procedure. So, for example, if you were getting a colonoscopy or a gastroscopy, where they put a camera down your throat to have a look if you've got reflux or something like that, you can still have food in there even if you haven't eaten in a couple of days, just because of the way it works. They also inhibit inappropriate post-meal glucagon. So glucagon is another hormone like insulin, and they work the opposite to each other. So insulin takes up sugar from your blood and puts it in your muscles. Glucagon works the other way around, so it takes it from your muscles, puts it in your blood. So it just changes your hormones so that you feel full for longer, that you've got a stomach full of food for longer, and your sugars are better because of that hormone control. So it works fantastically. They're like a miracle drug, the way that they've been working with our patients at the moment. So what are some side effects? Side effects are super, super common. Most common side effects are nausea, vomiting, diarrhea, indigestion, reflux, and heartburn. So up to 50% of patients. And the patients that I've prescribed this in, I'd probably say it's up to 100%. Almost every single patient will have a side effect of some sort. The good news is that almost all of these side effects will get better after a time. So usually a time is somewhere in the vicinity of 1 to 2 months, and usually the side effects will get better by themselves. If you step up in the doses, the side effects can come back. If they're okay and you're managing them, then you can carry on. If they're really, really bad, you might find that you might need to come back on the dose a little bit and stay on the lower dose for just a bit longer so your body gets used to it, and then go up. The other thing is you can do things like split dosing. So you might go up to, say, 0.5 milligram or 1 milligram. What you can do is do a half dose at the start of the week and a half dose halfway through the week, and that might work a bit better. You might find doing doses at nighttime might work a bit better, because you get the worst of your side effects usually in the first sort of 12 hours after you have a dose. So if you're sleeping, it's not so bad, although some people wake up because they've got bad reflux. But the side effects, as in the nausea and vomiting, very, 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 very common. Constipation as well. Rarer side effects, pancreatitis is usually, so pancreatitis is when your pancreas, which secretes the insulin, gets all inflamed and angry, really, really painful. So it's not a little bit of pain. Like if a patient comes in and says to me, I think I've got pancreatitis, I'd say you probably don't, because you're just sitting here and you're telling me you've got pancreatitis. Pancreatitis is one of the most painful things ever. Kind of like a kidney stone. Very, very, very painful. So if you've got pancreatitis, you wouldn't be sitting there, you'd be, rolling around the ground. So if you've got a little bit of pain, it's probably not pancreatitis. If you've got a lot of pain, it's definitely something that you need to let your doctor know, and or go to a hospital. Pancreatitis is very serious. It's incredibly rare, though. I have never seen it in all the patients that I've prescribed, and I've probably given this out, 1,000 times. It's incredibly rare, but it does happen. It seems to happen more in the context of gallstones. So if you've got known gallstones, it's probably something you need to let your doctor know, because going on this medication can increase the risk of that. If you previously had gallstones and then had your gallbladder out, generally that risk is lower. But your body can still produce gallstones and they can still go to your pancreas even without a gallbladder. Another thing to consider is low blood sugars. So the injection by itself won't give you a low blood sugar, so it's completely safe like that. But if you're on another medication as well, so if you're on insulin, if you're on a medication called glycoside, which is another diabetic medication, if you're on that one plus Ozempic or something similar to Ozempic, so Saxenda, etc., the risk of you having a low blood sugar is increased. So that's something that your doctor should be aware of when you talk to them. Changes in vision. This is more important for people that have diabetes and have diabetic retinopathy. Diabetic retinopathy is just a fancy way of saying that the diabetes has affected your blood vessels in your eye, and you need to see an optometrist every so often. If you've got that, the Ozempic can make that worse, so that's something to keep in mind of. Kidney problems. Kidney problems are usually in the context of dehydration from vomiting. So the Ozempic itself won't give you kidney problems, and Ozempic probably actually is good for your kidneys. But if you've got really bad side effects, you're just vomiting all the time, your fluid levels are going to go down and that can affect your kidneys. And then thyroid tumors. This again is incredibly rare and no one's ever seen it in humans, but when they use the medication in rats when they were testing it, so this is, 10 years ago, a few of the rats did get thyroid tumors. So you'll probably hear on the forums people saying, my doctor didn't give it to me because, I've had thyroid problems. It's pretty specific to a certain type of thyroid cancer, so it's medullary thyroid cancer. It's incredibly rare itself, and it's never, as in Ozempic, has never been associated with it having in humans, but it's a theoretical risk that could be there. So in general, we tend to not give it to patients that have had specifically thyroid cancer. Now, if you've had thyroid cancer and had it removed, as in your whole thyroid's been cut out, it's probably best to talk to your either ear, nose, and throat, so the surgeon that removed it, or your oncologist about the medication if that was something that you were considering to use. But it's very, very rare, very, very rare. Pancreatitis and the thyroid issues, incredibly rare. So what are other considerations? So considerations, if you're on this medication, if you've got the pancreatitis, if you're going for any sort of surgery, you need to talk to your anaesthetist or surgeon. If you're using insulin and glycoside, that's a type of medication for diabetes, you need to be aware that you could have a low blood sugar, the medullary thyroid cancer, and the other type of cancer that we're aware of is multiple endocrine neoplasia, or it's called MEN syndrome. That's something that you need to be aware of, or your doctor should be aware of if you've ever had that. If you've had that, generally you wouldn't prescribe it to you. This type of cancer is incredibly rare. So Ozempic doesn't give you this cancer. This is the type of cancer where we don't give you Ozempic. And I've never seen this type of cancer. It's incredibly rare, but it's something to be aware of, or make your doctor aware of if you want to go on it, of course. If you're type 1 diabetic, we can use Ozempic in type 1s, and there's some new studies coming out saying it's actually very, very effective at regulating insulin use. But generally, I would see an endocrinologist first to get the tick off for getting that. So I have a few patients that I share their care with endocrinologists, and they're on Ozempic, and it's working very, very well. So it's a great medication, works really well in a whole heap of scenarios, but it's just making sure that your whole team that's caring for you is aware of the issues that could be occurring. So what about the good stuff? We've gone about all the bad stuff. What about the good stuff? So Ozempic specifically, but all the GLP-1s in general, fantastic for weight loss. Ozempic, usually you get up to 18% weight loss. So if you were 100 kilos, you'd lose about 20 kilos. That's fantastic. However, remembering that's at the weight loss dose. The weight loss dose is 2.4 milligrams. So if you're not losing all that weight and you're only on 1 milligram, it's probably because we just need to increase the doses. There was some new studies saying that decreases, not increases, it decreases your risk of heart attacks. So that's awesome. That's yay. And it's probably good for your kidneys as well. The reason why I say probably is that some of the studies weren't totally sure of that, so that didn't meet certain criteria, but it probably is helpful for kidneys. I wouldn't give it to a patient just for kidney issues. I'd give it to them if they're diabetic or want to lose weight. But as a byproduct, it just probably good for your kidneys, and it's also good for your heart. So it's a good medication overall. Has pretty few side effects. Works really well. So what are some changes that are coming about in the medical field because of these medications, and also I think because of our understanding of obesity and weight loss. So before we used to think of obesity as a sin. You got it, and you got it because of your own choices. But now we're considering it as like a disease. So someone who has diabetes, that's a disease that we treat, and we use medications, and we recommend seeing a diabetic educator and a psychologist, an exercise physiologist, a dietitian, and all these sorts of things. And if you've got heart disease, so if you've ever had a heart attack, we recommend you go see a cardiologist, and you start these medications, and so on and so forth. No one considers people having heart attacks as a disease of sin now. You didn't have a heart attack because you caused it to yourself. It's a disease that we just treat. Obesity is starting to change into that. So you'll still find a few people that will see obesity as, this is your fault, but we now consider it as a disease to be treated and managed just as any other disease. We've got a lot of treatment options available, so the ones that we've talked about. And then we've also got this recognition that a lot of the medications that you can be given for completely different things can cause problems with weight, as in weight gain. So here's a list of medications that cause weight gain. They're very, very common. Of all the patients in Australia, probably about 60–70% are on some form of these medications. So antidepressants, so things like Zoloft, Prozac, sertraline, antipsychotics, prednisone, which is used very, very commonly. It's a steroid. Contraception, so things like the pill, could cause weight gain. Insulin, that can cause weight gain. Glycoside, that's that diabetic medication. Pain medication, so NDEP, that's a really common one. And then medications for epilepsy. So if you look at that list, you'd probably find that almost everyone has probably been on one of those at one point in their life, at one time or another. So what is optimal therapy? So Ozempic is fantastic by itself. Here's this injection, here's this magic drug, you'll lose some weight, perfect. But in general, I've found that patients will lose weight faster and keep it off longer if they have a team approach. So dietitian that can go through your diet history, exercise physiologist help you with some exercises, psychologist, they're people that can help you, talking about your eating habits, bariatric surgeon if that was something you were considering, and endocrinologist as well. So all these people can have a really good input into your weight loss journey, and I think they're very, very helpful, and I always encourage my patients to go see them as well. Like we said before, good eating habits and exercise by themselves don't add a lot to weight loss, but the idea is that they will add to your weight loss journey and keep you fit and healthy, keep your heart strong, your lungs strong. The other thing that we've got to consider, we always talk about weight loss, weight loss, weight loss, weight loss. The other thing to consider is healthy at every size. So just being your best self at whatever size you're at, and that is okay. So being the healthiest you can be at the size you're at is okay. Sometimes we do have an over emphasis on weight loss. I've got to be this weight and, look like this and things like that. But, being the healthiest you can be and the happiest you can be is also okay and encouraged. So future considerations. So this is a bit of a hot take from myself, but I think that in maybe 5 to 10 years, weight loss surgery will be very, very, very rare. And we will probably just exclusively use medications for weight loss. And that will be either with these new medications, which we'll talk more about in a few future sessions that we've got coming up, plus also, diet, exercise, and some types of supplements and things like that. So we're discovering new weight loss medications. We're also figuring out that new types of exercises are more helpful. So you possibly have heard of HIIT training. So that's a high intensity interval training. We're finding that is, really good for your cardiovascular health. So good for your heart and lungs, and good for weight loss. Probably doesn't do a whole lot for your joints though. So that's the one thing it doesn't do really well. And then we're finding that putting in or being in contact with the psychologist can be helpful as well, just to help with keeping the weight off. So new medications which are coming out, Ozempic, which is fantastic, Mounjaro, which hopefully will be out soon. Combining that with a few other things, I think in the future it'll be rare to see surgeries actually. So a few dietary recommendations. This is a question that comes up. What sort of diet should I go to? I think seeing a dietitian is a great idea. So I encourage all of my patients to see one. We'll talk more about seeing a dietitian in the Money Hacks one, but you can see them under a care plan, so a GPMP. That's what you'd get with the GP. So you can get a care plan for obesity, and then you can see a dietitian for a bit cheaper. So the government will fund that. So they pay about $50. The government will pay $50 towards the visit, and then you sort of pay the rest. With the diet, what are some general recommendations? So ketogenic diet is a diet where essentially we're trying to decrease the amount of carb intake, increase the amount of protein and good healthy fats. So not like hot chips, which I love. Hot chips are great, but things like avocados are good quality oils. Fish, they have good fish oil. Increasing your protein as well. So things like egg, whey protein. We're finding that the same drug that Ozempic is, so the GLP-1, there are natural versions of that, and they're probably in eggs, codfish, and whey protein. So eating those is a natural version of the GLP-1, so Ozempic, and will make you feel fuller for longer. So help with that satiety, so you feel satisfied. There are some supplements around. Supplements are a bit of a gray area. You always find someone sort of selling some random supplement and you're not totally sure if it works or not. There is some evidence for spirulina. So spirulina is a supplement that seems to work reasonably well, and it's cheap. So it's, you don't need a specific brand, just a cheap brand. That's a helpful medication. So if you look into Google, and I've got a study on the bottom of this slide, which I'll put in the chat as well. Spirulina helps people feel full. It also helps regulating their ability to snack, and it helps with weight loss as well. So if you took it by itself, you can lose a couple of kilos. It's not going to be huge, not as big as the medications, but together with the medications, that would be something to look at. So you've got a few dietary recommendations. Ketogenic diet seems to be, it is a really good basis for weight loss. The way it works is that you're using ketosis, so a different type of energy form. So instead of carbs, so you've heard of the term carb loading. Carb loading when you eat a whole pasta, right? So you're not eating carbs, so your body changes the way it makes energy, and that's called ketosis. And those ketones which the body produces seem to make you feel full and not wanting to eat. So there is good data for ketogenic diets as well. I think seeing a dietitian is great. I wouldn't say I'm overly fond of saying, let's do this diet or let's do that diet, which is the reason why I really like Ozempic and things like that. When we talk about weight loss, it's got to be sustainable. So you're on a journey, and that journey's got to be fun. You've got to be able to keep going on that journey. If the journey is, juicing celery for 6 weeks, and then you eat nothing except for celery juice, you're not going to like life. Food is an important part of our life. It's something that we break bread over, get to the family, meet, catch up the family over, have Christmas, things like that. So it's an important part of our life, our culture, traditions, things like that. So I'm not overly fond of saying, let's try this one diet. And then, you have all these events coming up and you can't eat anything because nobody else juices celery. So I think whatever you do, it's got to be sustainable. So that's where a dietitian can come up with an individualized diet plan. So a diet plan that's helpful for you. So I think that's a great idea, and I recommend it to my patients. So common questions. We'll go over a couple. So how many doses do the pens have? So you got the red pen, which is the starter pen. That's the 0.25 and the 0.5. It's got a total of 2 milligrams. So that means you could have 4.25 doses. So that's 4 weeks of 0.25 and then 2 weeks of 0.5, and that's the total. The blue pen has 4 milligrams, and you can click it around. So I'll put this clicking table in. You've probably seen this around. So the the big pen, which has the total of 4 milligrams in it, or the 1 milligram pen, it's also called. You can take the 1 milligram each week for 4 weeks, and that's 4 milligrams total. Or you can get that pen from the start and just click it around like this clicker. So if you wanted to go up to the 0.25, you do 18 clicks. So you click it around 1, 2, 3, 4, 5 up to 18, and just do that. The pens will last 8 weeks. That's what the manufacturer says. So 8 weeks is the total length of, sort of from when you open to expiry. So if you use it within 8 weeks, it should be good. In terms of the usual dosing is 0.25 for 4 weeks, then 0.5 for 4 weeks, and then 1 milligram after that. That is the diabetic dosing, should I say. So that's the usual dosing we use in Australia because we only have those pens available. Once Wegovy comes out, which I've been telling patients, oh, it should be at the end of the year. The end of the year is pretty much upon us. So it probably will be next year, early next year, hopefully. We'll see. The dosing would be 0.25, 0.5, 1, 1.7, 2.4. That's sort of the progression. If you have symptoms along the way, you dial it back. So it depends on how you're going with your symptoms. So if you catch up with your healthcare provider that's giving you the prescription, they can give you an idea of what we can do in going up. But that's the general gist of increasing the doses. Another question, how come I'm not losing weight on Ozempic? So I've tried it. I'm on 0.25. I've been on it for 2 weeks. I haven't lost anything. So the 0.25 milligrams is actually a placebo dose. So it's just to get you used to the medication. So placebo means it probably doesn't do anything. It's the same as having water or a sugar pill or something like that. So it takes 4 weeks for you to get used to it. If you lose weight in the first 4 weeks, it's probably not because of medication or anything. It's just because you wanted to lose weight, which is what placebo is. The reason why we don't do placebo for other medications is that it's quicker to come back on. So if you just stayed on the 0.25, you would lose weight because you're doing well, and you'd probably lose. I've seen some people lose a lot of weight just the 0.25, but that's all just willpower. So they're doing really great. They'll put it back on a bit quicker. If you go up the doses, it tends to stay off for a bit longer. 1 milligram is a diabetic dose, so that's just the dose for people that are on diabetes. They can go higher if they want to lose weight, but in terms of control of sugars, 1 milligram seems to be the good spot. 2.4 milligrams is not better than 1 milligram at controlling sugars. It's better for weight loss. The studies were done over 2 years as well. So if you've been on it for a month and you're not losing weight, bear in mind that the people who were in these studies that lost up to 18% had been on it for 2 years. It's hard to be on this medication for 2 years at the moment because it seems like there's a bloody shortage every other week. So you start it, you stop it, you start it, you stop it, you sort of, you bounce up and down in between those. So it's very frustrating because, you lose weight and you're happy with those results, and then you stop losing weight because it's not in stock anymore. So it's very frustrating. You just got to keep the faith. Almost every single person that's been on this medication will lose a significant amount of weight loss. Not everyone loses 18%, but a significant amount of people will lose a significant amount. The newer medication, the Mounjaro, that's up to 22% weight loss, which is like incredible. So it's another 25% more effective than Ozempic. So that's a medication that's hopefully coming out in the next couple of weeks. The price of that, it's probably going to be priced similar to Saxenda. So that's about $300, $400 a month. So a bit more expensive, but it is more effective as well. So storage and expiry. Where can I store it? So this is straight from the Ozempic Novo Nordisk website. So you can chuck it in your fridge, and then you can keep there until the expiration date. So that's if you haven't opened it. If you've opened it, then you've got 56 days. So that's 8 weeks, right? 7, 8, 56. So you have 8 weeks to use it. You can store it at room temperature. I'm pretty sure that's new. I remember when I read about this medication about 2 years ago, they said, just keep it in the fridge, but you can store it at room temperature. So if you had to fly anywhere, you could take it in your, in your luggage, and it should be okay. Generally, luggage would be, if you put it in the undercarriage, it would be really cold down there, so it should be okay, but it's hard. But if you took it as carry-on, the temperature of the plane should be fine. In terms of disposal, I'd recommend people getting a Sharps disposal box. You can get them pretty much at any chemist. They cost like $10. You just chuck all the needles in there. Some pharmacies will also take your needles, so you can give the needle heads, to the pharmacy, and they'll dispose of them. So there's a website there that you can have a look at, and that's for the disposing pharmacies. When you come in and see them, they might give you funny looks because the disposing of needles is more in the context of IV drug users, not Ozempic users. So they might sort of look at you funny, like, you're injecting heroin or something. But they should still be able to take the needles. But generally, a yellow, a little yellow box probably works better. It's easier. So where can we inject? So similar to insulin, if you've ever used insulin or anything like that, you can inject it just under the skin, so subcutaneous, and in all the areas on the picture there. The same as insulin, we'd recommend that you rotate it. So the easiest way to rotate it is just, different sides of your belly, different thighs each time. Theoretically, if you just move it a couple of centimeters, it should be fine. The reason why we say inject it in a different area is that you can get skin changes. So if you're injecting in exactly the same area, every week's not so bad, but with insulin, you're doing it a couple of times a day, right? your skin can get some changes in it which don't allow you to absorb the medication. So that's the reason why some diabetics will be injecting, and they inject the right dose, but their sugars are still not that well controlled. It's because they're not absorbing it. So with the Ozempic, it's the same sort of thing. You want to be injecting in a little bit different area to make sure that the absorption is coming through. Remembering when you take off the cap of the pen, you've got the big blue cap that you take off, then you got the little cap, which I've had some patients that don't take that off, and you got the little needle. The needle has to go in. You hold the pen and you hold the pen, the button that you're pressing, hold it for 10 seconds so that the full dose goes in. If you sort of just press it or just squirt in a little bit, and it won't get the full dose. The other question that comes up, which we talked about a little bit, I've stopped losing weight. So I lost a whole heap of weight, 10, 15 kilos, 20 kilos, and I was doing really well. And now it's just stopped. It's probably just dosing related. So the studies are up to the 2.4. Hopefully the Wegovy, which is the 2.4, which is exactly the same as Ozempic. They're exactly the same medication. It's semaglutide. Hopefully when that comes out, you'll be able to increase the dose up to the 2.4 and continue losing weight. I'm getting mad reflux. So this is probably the number one complaint, number one question you get. You're getting mad reflux. It's super, super common. It's just related to gastroparesis. So gastroparesis just means your stomach is slowed down. So gastro, stomach, paresis, paralyzed. So your stomach doesn't empty. So your stomach goes, there's still food in here. I need to digest it. I will create more acid. That acid gives you reflux. So here are some tips. You can reduce your meal size, which helps with weight loss. In terms of the meals you're eating, just make sure they're not particularly fatty. So deep fried foods, dairy has a fair bit of fat in it. Obviously cake and lollies and things like that. Spicy foods. You want to sit up for a couple of hours after your meal, so don't lie flat. So it's just gravity. Try and not eat meals immediately before bed, and especially if they're going to be fatty. So sit up for your last meal of the day and eat your last meal of the day a bit earlier. So 5, 6 o'clock if you're going to bed at 9. Don't drink water with your meals. It just dilutes the acid, so you produce more of it. Try and drink it before or after. You can try some things like Gaviscon or Mylanta, so they're just over the counter. They might help. If they don't, you might need to get a script from your doctor for like a reflux medication, so like Nexium. With the symptoms, they generally do get better. So if you get mad reflux, usually it should get better in the next probably about month to 2 months, depending on how you're stepping up the dose. But almost all people that have symptoms, remembering that's about 50%, almost all of them will get better without doing anything. So without needing any Gaviscon, Mylanta, or Nexium, or whatever, it'll just get better by itself. Usually that's in the context of one, you're getting used to the medication, and two, you're probably reducing your meal size so you don't get those symptoms. And it almost always goes away with most people. My reflux is so bad, I'm getting sweats, nausea, stomach pain. So this is probably still reflux related. If it's bad enough, it can activate your vagus nerve. So you've possibly heard of the term vasovagal. So when people sort of faint, so someone, has some pain somewhere, someone hits them and they're in a lot of pain and then they faint, or they've got stomach cramping and they faint. So we call that a vasovagal. There's this nerve called the vagus nerve, and it wraps around your stomach and is involved with digestion. If you get bad enough reflux and indigestion, so your stomach's really, really upset, it can trigger that nerve, and that nerve causes low blood pressure. So all of a sudden you just get low blood pressure. Can be very, very uncomfortable, like very, 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 very uncomfortable. And this is where it can be difficult to tell between, something like pancreatitis, because you're pretty unwell, and then also low sugars. So a low sugar can present the same way. You get sweats, you just feel lightheaded, you feel unwell. So they're things that you definitely need to talk to your doctor about. It's probably just the medication. It will probably get better, but it's important for a few people to know just in case it doesn't get better. And you're having these things. So the patients that I've had like this, I've stepped back the dose until it's tolerable, and then we keep going on the lower dose for a couple of weeks, so maybe another week or two, and then try stepping it up. Then split dosing is another thing you could do. So we talked about having a half dose at the start of the week, half dose at the mid of the week, and see if that helps. But if something is like this is happening to my patient, I want to know about it and try and figure out, how we can improve the situation. So that was all that we had for tonight. Were there any other questions? I think, let me just pull up the chat. I've got a feedback form. It's just asking about, if the session was helpful, if there's anything else that I could put in the sessions. If you thought hearing from a an endocrinologist, which is say a specialist in diabetes, or a bariatric surgeon, or a psychologist, or a dietitian, if you thought that would be helpful. They talk about different things than what I talk about. I'm a GP. So if there's any feedback about it, you can have a look at this form here. And if you want to ask any questions in the chat about how it all works, I'm happy to answer them. My thought around this whole session was, if we can figure out how how Ozempic works, how the medications work. I know that there's a lot of questions that come out, and it's not always, it's pretty hard to get into your GP these days. I know that. So I have a lot of patients telling me that. So what else can we add to these series that will be valuable to hopefully give you a few answers, save you having to worry about them. Something that comes up, so alcohol, so issues with alcohol. So alcohol is actually pretty good at causing weight gain. It's got a lot of calories in it. There are some studies that have recently come out actually in the last couple of weeks, so it's good that you brought up this. With alcohol, we're finding that people that drink Ozempic probably want to drink alcohol less, because it works on the same centers in your brain that are related to wanting to eat and satiety. So people that take Ozempic tend to take, I say it with sort of quotes, but like things like alcohol, drugs, cigarettes, even less. So it seems to work a similar pathways, so that you're not wanting to do those things. In terms of, are you able to drink alcohol on it? You can drink alcohol. You'll probably find that you just want to do it less, the same as you want to eat less, eat smaller meals, things like that. So there's nothing specifically wrong with it. Like if you drink it, you're not going to be any more or less upset in terms of stomach issues than any other food. Everyone's a little bit different, so everyone has triggers that make their stomachs the stomach more upset than other things. So alcohol is not more or less worse than anything else, but it is very high calories, and high calorie things can make you a bit more upset. You'll probably find that you just want to drink a little bit less of it, because we're finding the studies are saying that it's actually good for these sort of alcohol, cigarettes, things like that. That's really new information, so we're not 100% sure on it, but it just tends to be like that. But yeah, if there's any other feedback, so yeah, a dietitian, I think that'd be helpful. Any other feedback, any other thoughts, questions? We've got another session in 2 weeks' time. So we'll go over the top 5 medications for weight loss. So I know we've touched a lot on Ozempic. Next time we'll touch on a few other different ones. So Saxenda, Trulicity, Duromide, Topiramate, and just go over side effects and things like that. If there's any other questions, leave them on the feedback form, and I'll have a look at them, and we'll try and make the sessions helpful for you. Apart from that, if we're all good, I think I got one more question coming through. Maybe. Looks good. Good. Well, I'm glad you enjoyed it. So any questions or anything, let me know. I'm floating around the Facebook group as well. And we'll leave you to it. Thanks very much for attending. I really appreciate your time. We'll leave you to it. See you later.